You're watching Managing Your Asthma by Dr. Lisa Gall on Resonance Wellness TV, part of our Whole Life Medicine Alleviate series. Keep in the loop about future webinars and events on whole-life-medicine.com. Hello, and welcome to Managing Your Asthma. My name is Dr. Lisa Gall, and I will be your guide this evening about all things wheezy. Now, this presentation, as usual, is given in the context of the whole life medicine model. And when we talk about asthma, we are talking about starting points in alleviate predominantly. There are also some issues in align in the WLM model. And hopefully, all of you have heard me speaking about these aspects before. And this is going to be an interesting presentation because of how much is really not known directly about how asthma comes to be. There's a lot of correlates, but not a lot of great proof of clear reasons why. So that is in part what we're going to be exploring today, because I'm sure if any of you have asthma, one of the biggest um, issues is that the medicines for it don't really cure it. And it doesn't really behoove anybody to be on too much asthma stuff for too long. So usually we have this habit in our culture. If we don't understand something, we define it by some very narrow parameters. And in this particular case, that narrow parameter is by what things have an impact on it, but it's not very individualized and often not super helpful. And so this, like I said, this presentation is interesting because I realized as I was researching, because it takes some time usually to research these things and put together a cohesive presentation, that it's really unclear to medicine in general how this is being produced. And so, like I said, we're going to talk about that a little bit today. It's really unfortunate because it makes for a not so easy treatment approach, or it's very can spam treatment approach, as you may have already experienced. So just to kind of start off, we're going to do what we usually do and just remind people about facts about asthma. And so asthma affects people all over the world. It affects people of all ages. And in Canada, it's actually the third most common chronic disease. It's actually the most common chronic disease amongst children, and it's a major cause of hospitalization for children here. It's estimated that 3.8 million people in Canada currently suffer from asthma. Approximately 850,000 of those are children under the age of 14. About 317 Canadians get diagnosed with asthma every day, and a severe asthmatic case, which is a greater threat to health, impacts about 150 to 250,000 Canadians. And severe asthma is defined as when you have continued asthma symptoms and frequent worsening of asthma symptoms, and also attacks amongst patients who take multiple asthma medicines, even with a high degree of compliance and good trigger management. So some Canadians are hit harder by asthma. It's about 40% more prevalent amongst First Nations, Inuit, and Métis community than in the general Canadian population. And I think there's probably some good reasons for that, and we're going to come back to that shortly. So other than that, I think we have to think about asthma as being really a group of inflammatory conditions of the airway, and it's characterized, by three major things. One is chronic airway inflammation. The second is bronchial hypersensitivity to a trigger. And the third is transient respiratory obstruction. So we're going to look at this diagram here, where you're seeing kind of a visual of this. So on the left-hand side is a normal airway. So what you're seeing there are relaxed, smooth muscles on the outside of the airway. And on the inside, you're seeing a normal inside respiratory lining without too much swelling. So when you have asthma, especially in the middle, which is a basic asthmatic airway. That's literally kind of like the set point or the normal state of the asthmatic airway. So, what you're going to see there is the wall of the inside lining of the respiratory tract is inflamed and thickened. And on the extreme right here, you're also seeing that same thing, but with tightened, smooth musculature around the bronchus. And you're also seeing yellow for increased mucus production. Also, there's a narrower lumen there. So even a small amount of mucus ends up being a bigger amount of mucus when it is stuck in a smaller hole. So, in essence, it makes breathing difficult and it's triggering the common symptoms of coughing and wheezing and shortness of breath. And for some people, of course, asthma is only a minor nuisance, and for others, it obviously causes significant problems that interfere with daily activities, and that can even lead to life-threatening situations. Surprisingly, in this country, less than 250 people per year die of asthma. Um, Considering the sheer numbers of people that are affected, that's quite a low number. But still, I mean, that's 250 people. So next, what we're going to look at is typical signs and symptoms. And as I said before, we have the common asthma signs and symptoms of shortness of breath and tightness in your chest. But some people don't realize that asthma might present by trouble sleeping, where people just can't seem to get comfortable breathing at night, both independent and codependent with sleep apnea. And sometimes people also cough at night or wheeze at night. Um, People with asthma often are affected by a whistling or wheezing sound when they're exhaling. And of course, it's often increased substantively by respiratory infections. So even simple colds or flu-like illnesses can aggravate asthma quite a bit. And sometimes that's how it gets diagnosed, is that somebody has a significant infection and then has trouble breathing both during and after. In an attack, the wheezing and coughing and chest tightness are severe and constant. And it's really defined really by being too breathless to eat, speak, or sleep. Full attack. People usually are breathing faster under those conditions. They have a fast heartbeat. They may also get drowsy or confused or dizzy because you're getting less oxygen into the brain. Worst case scenario, you'll see blue lips or fingers and loss of consciousness. So there's quite a range from like daily types of symptoms all the way into full on unmitigated attack. So, who is at risk? Some components seem obvious and some are really not as direct. The most common risk factors for developing asthma is having a parent with asthma, having a severe respiratory infection as a child, having an allergic condition, or being exposed to certain chemical irritants or industrial dusts in the workplace. And so let's take a look at the list. So um, these are the most common risk factors for people developing asthma. So if you have a parent with asthma, you're 3 to 6 times more likely to develop asthma than someone who doesn't have a parent with asthma. That's quite significant. Of course, there have been attempts to find genetic direct correlates to this very common condition, but it's not as simple as that. The second thing that's a risk factor, like I said, is viral respiratory infection history. And so if you've had a significant respiratory problem during infancy or childhood, I mean, you can obviously cause wheezing early on, but some children who experience that kind of infection with wheezing go on to develop chronic asthma, and it will be it's a known trigger. Having an allergic condition like atopic dermatitis, otherwise known as eczema, or allergic rhinitis like hay fever, those are risk factors for developing asthma. Of course, they are their own conditions and also have impacts specifically allergic rhinitis on the respiratory tract, but they're often found together. So it's not unusual, as an example, in my practice to see a child with eczema, especially suppressed eczema, develop asthma. Um, and so that is a huge risk factor, just environmental allergies. Occupational exposures are another major risk factor. Exposures to certain elements in the workplace can directly cause asthma symptoms. And for some people, exposure to certain types of dust, like industrial or wood dust, chemical fumes, vapors, and molds can cause asthma to develop for the very first time, even as an adult. Smoking is a kind of well, duh sort of risk factor. It irritates the airways to smoke cigarettes, and smokers have a high risk of asthma. Those whose mothers smoked during pregnancy who were exposed to secondhand smoke are also more likely to have asthma. The next is air pollution. Exposure to the main components of smog, like ozone, raises the risk for asthma. So those people who grew up or live in urban areas have a higher risk for asthma, and sometimes it is the hugest risk. And it actually is one of the things that we see dividing socioeconomic status and asthma status, because often those areas that are more polluted end up being places where people with less money live. And so you'll see some correlations to not being able to deal with air pollution in the summer in an urban environment, as an example. Not being able to cool a room or filter the air because you just don't have the money to do that. And last but not least, obesity. So children and adults who are overweight or obese have a greater risk of asthma. And even though the reasons are not super clear, it's probably related to inflammation in the body occurring with extra weight. It could also be related to more medications, because obese asthmatics suffer worse symptoms and are less able to control asthma than people in a healthier weight range. So, like I was saying, there's additional factors: poverty, um, lack of appropriate access to healthcare. Um, it just basically contributes to more asthma symptoms, more emergency room visits, and more hospitalizations. So, um, to to kind of delineate, so these are risk factors. Some of these risk factors are also obviously triggers. The common triggers that people have really vary from person to person, but the most common triggers include reactions to airborne substances. So the pollens, the dust, the mold, the pet dander, insect waste, particulate, the exposures to occupational chemicals, which we already talked about in terms of occupational asthma. And really, the number of cases of asthma due to occupational exposure is unknown, but probably about 15% of asthma cases in Canada are job related. Irritants in high dose that are most likely to trigger occupational asthma are hydrochloric acid, sulfur dioxide, or ammonia. Additionally, if people work in like a detergent industry, they can really develop a sensitivity to the enzymes that are often used in the detergent enzymes, which are coming from a bacteria, actually. And even bakers can get symptoms from like flour dust or baking enzymes. So you'll see these all as common occupational risks. There's also, like we spoke about, the trigger of respiratory infections, such as a common cold. So somebody with the diagnosis of asthma is more likely to go into a trigger or attack situation when they have an infection. Physical activity and exercise, pretty much 90% of people with asthma have exercise-induced bronchoconstriction. Obviously, that can occur in people without asthma as well, but if you have asthma, it's not uncommon. Cold air, especially cold, dry air, is a trigger. We live in Calgary. We have cold, dry air most of the time. Smoke from cigarettes, like we said, direct or secondhand. Vaping also will do it. Wood fire smoke, like when you go camping with a lot of other people around you. And fireworks, being in a situation where you're too close to where the fireworks are being set off or you're downwind from fireworks. Volatile organic compounds like those that come out of paints can trigger it. So sometimes people with asthma need to be careful about what sort of products they're putting in their house. You don't want too much fresh formaldehyde or fresh paint that's got a higher VOC content. Gas stoves also can create enough particulate to trigger asthma, even though they're lovelier to cook on. If you're asthmatic, they don't always burn clean enough to not aggravate your asthma. Microplastics, inhaled microplastics, and ingested microplastics may also be an issue. I don't know if you all are familiar with that, and you've certainly done some work in environmental medicine lectures before on this, but microplastics are like nanoparticle sized plastic chips that are coming from really the non very biodegradable plastics that we've been using now for decades. And a lot of people who have asthma postmortem have a significant amount of microplastics in their lung tissue. Now, certain medications also can trigger asthma. Beta blockers can do it. So those are heart medications. Aspirin can do it. Ibuprofen, naproxen. I mean, these are common NSAIDs. So beta blockers increase airway reactivity. And they also interfere with the activity of the beta agonists, which are used in inhalers. Ibuprofen causes the airways to narrow. They actually creates increased bronchospasm. And aspirin-induced asthma is really basically a separate recognized asthma. Um, and about 20% of adults with asthma will have aspirin-induced asthma. And what's interesting about that is lots of people eat compounds that are aspirin-like. So you can have salicylates in your diet actually be a trigger cause for asthma. And they're in some very common foods, like cucumber and tomato and tea and coffee. And it really depends a little bit on the person, which of those tends to overload the system that gets rid of salicylates. But if you haven't discovered what your asthma trigger is yet, that is a definite rule out, especially as an adult. Strong emotions like stress create it, sulfites, preservatives, things that you find on dried fruit or processed potatoes, sometimes in beer and wine. And also, last but not least, gastroesophageal reflux disease can actually trigger asthma as well. And sometimes that'll trigger it when people can't find the obvious trigger. So, things that make it worse, definitely cold air. So basically winter. And especially when the change to cold air is rapid. So people going outside without like a scarf over their mouth, if they're asthmatic, that can actually induce an asthma attack. Dryness in the air, which again, we tend to suffer from incredibly. Our air pollution has gone up and down in recent years. Obviously, we've had some pretty bad smoke years, which have been a little bit difficult for people with asthma. Chlorine in swimming pools. So chlorine levels in both the air floating above the pool and water can cause breathing problems in asthmatics. So it's worth looking for a salt pool. Chemicals on ice rink resurfacing equipment can actually increase asthma attacks. So in a little hockey player, the coldness and then all that resurfacing stuff that they use in the Zamboni. Also activities with extended periods of deep breathing. So if you're like a long distance runner or swimmer, like I said, or soccer, something fairly aerobic game over the long haul, that's often an asthma trigger. And like I said before, I actually mentioned this already, but microplastics in the lungs, they really do create inflammation, asthma-like symptoms, and tissue damage. Now, this is a great quote I came up against when I was doing research for this. And I love this quote: asthma is like love. We all know what it is, but who would trust anybody else's definition? And this is a quote from a doctor who is basically a very honored expert of respiratory physiology and medicine, and his specialty area is asthma. And here I'm just giving you an illustration of some of the things that we just talked about that are potential triggers, any or all of which could be helping to increase your asthma risk, asthma attack risk. So, like I said, we're coming to this conundrum here because obviously different endotypes of asthma have basically a very similar clinical syndrome. So everybody understands the mucus hypersecretion and the inflammatory and like edematous swelling of the airway mucosa and also the bronchospasm. And in fact, those three things together are called a Herxheimer triad. People might have heard of Herxheimer in terms of detox reactions as well, but this is the Herxheimer triad. I mean, basically, you can describe asthma by its clinical associations or what appears to be underneath it, and these are not equivalent. So this is why I'm showing you these two little graphs of clinical versus phenotypic asthma. So if you look at the clinical side, you're looking at, the allergic asthmas. So hay fever induced asthma. You see it in childhood. You see eosinophils, and it responds well to inhaled steroids. You see late onset asthma where it's non-allergic, not as much, and basically have this persistent kind of low airflow. You see aspirin exacerbated respiratory disease, like we talked about. There's that's more associated though with nasal polyps. There's flare-ups after taking aspirin or NSAIDs, and often it's more severe type of asthma. And then if you look at phenotypically, what that means is if you look at like markers, like the most common form of asthma is the asthma with type 2 inflammation, allergic eosinophilic asthma. So eosinophils are a certain white blood cell type, and they're elevated in this kind of asthma. And this is about 50% of all asthma cases, regardless of age, and about 80% of cases in childhood. And in allergic asthma, this characteristic inflammation is developing on the basis of the allergen-induced hypersensitivity reaction. And so you're getting this exaggerated immune reaction that are inappropriate, and you're basically getting swelling and white blood cell activation, which under normal circumstances is fine. We want our immune systems to be able to do that. But in these cases, it's having an impact on an area that is too marked and actually creating symptoms by a normal reaction. So we also have non-eosinophilic types of asthma where there's no eosinophils. And it usually responds to like different kinds of interventions. Like theophylline is an inhaler that's actually from the extract out of tea. That's where you get theophylline from. So like actual like tea leaves. That's where we originally got that from. And so we have all of these kind of mixed subtypes. It's not really super clear. And this is one of the biggest challenges about treating asthma is why is it happening under all these different circumstances? And I guess at the end of the day, we have to think about an asthma attack or wheezing as being something that is not really a disease per se by itself. The wheezing by itself is not a disease. There's clearly a myriad of different things that can happen in a respiratory tissue that triggers this particular reaction, but the reaction itself cannot be the disease by itself. And so this is, like I said, this is the biggest challenge. So how do you actually diagnose asthma? Sometimes I've actually met people who technically have a diagnosis of asthma, but it doesn't seem like anybody ever bothered testing them. And really, they don't seem to have typical asthma. Sometimes it's somebody who's just had one wheezing episode and then they were given an inhaler and told they had asthma. It's a difference between having an asthmatic reaction and having an asthma that's chronic. But often that doesn't get communicated very well. And so people are carrying around inhalers and sometimes using them because they don't want to have another wheezing attack like they had the first time, and they don't really need it. Usually we use spirometry to aid in the diagnosis of asthma. So on top of the blood tests that we can do, like I said, the eosinophils only show up in a certain population. I mean, it's very common, but it's only some people. And spirometry is a test where you blow into a machine. It's basically measuring how quickly you can expel air and how much air you can hold in your lungs. You can also use a peak flow test, which is a little handheld device. It's measuring how fast you can breathe out, and that has to be repeated often over a few weeks to see if it changes, if you're always in a certain flow, low flow or high flow state. And then you can do things like X-ray or an allergy test. You might have a chest X-ray to see whether or not some characteristic inflammatory changes and airway changes show up on that X-ray. That doesn't show up in everybody, but it often will show up in a chronic asthmatic. Or you might also be wanting to do allergy tests. In particular, IgE tests are done typically under these conditions, especially if there's like a hay fever component. There's also a test, which is an iron nitric oxide test. That involves breathing into a machine that measures the nitric oxide level in your breath, which is a sign of pulmonary inflammation. But this is not the most commonly available test here. A lot of the time it's used more for research. So I thought what I would do is talk about what are some common rule outs that you can think about. If you have asthma and you haven't had a chance to take a look at some of these items, but let's just talk about them here. So the first thing I would do is rule out allergies of both like hypersensitivity type 1 and delayed hypersensitivity reactions, which are independent types of allergy, and they cause different kinds of symptoms. So IgE allergies are more like the hay fever anaphylactic type, or the kind that produces hives or swelling reactions, like mouth swelling reactions. And those don't all they're not always as obvious as you'd think they are. Sometimes the only presenting sign of something like that is the odd hive and then asthma. So you don't have to go into full anaphylaxis to have an IgE sensitivity. And it's harder to get a big panel of those. We're used to using the scratch panels, and that'll work for like hay fever. Like if you have an environmental allergen, that's a reasonable test for that. But what I've found is that the IgE blood tests are much better. And typically I'd run a panel of at least, I think the panel we have is maybe 60 or 70 items, because a lot of the time the allergist will not run that many. And sometimes it's just something you don't suspect that's creating something in the background. IgG is the same. So IgG is, like I said, a delayed hypersensitivity reaction, but how it's the same is sometimes you're eating something that's really increasing the amount of inflammation in your body, and it's activating all of those like throat and gut associated lymphoid tissue and increasing all these white blood cell populations. And you have no clue because you don't have an obvious gastrointestinal distress associated with it. And because it's delayed, it's often not clear. It could be up to 72 hours before you actually have the wheezing associated with an ingested allergen that has an IgG reactivity. So you can actually do damage to your guts. That increases intestinal permeability. And that actually can increase like microbiome issues. I have microbiome issues here. So this is where your gut bacteria are just really not balanced. And there's lots of reasons for people to have this. One of the biggest reasons is we don't chew, we don't eat appropriately, we eat too much sugar, we eat things that actually increase the overall load of bacteria in our guts to the point where the defense system in your gut actually cannot keep up with how much bacterial toxins and messages are coming out of your own biofilm. And I've definitely seen people whose asthma exacerbations decrease substantively if they had an identifiable SIBO, as an example. That's small intestinal bacterial overgrowth. Now, you can also have dietary mismatch problems. So, one of those I already mentioned is sensitivities to salicylates. So, we see that a lot in certain subtypes of metabolic typing where there's a phenyl sulfur transferase enzyme that you can inherit with a little bit of a wonkiness to it. And it just doesn't remove the salicylates out of your bloodstream very quickly, and the salicylates are actually defense compounds in plants. They're the things that plants use to like make the bugs stop eating them. And so they're kind of irritants just on their own. And so if you don't clear them out really well, they can cause a definite aggravation. So normally I ask people if there's, especially if there's a lot of inflammation in their body that's obvious, to do metabolic typing because we can ballpark down what are the best foods to balance that person out. And long story short, and I've talked about this multiple lectures, and you'll find some directly on metabolic typing in the recorded lectures. But in essence, if you don't match what you eat, you stand a very great chance of making strange inflammatory problems. And not all people are created the same. Not all people can eat the same things. Not all people should be eating the same things over the course of their entire lifetime. And so we can make modifications specific to people that have huge impacts on inflammatory problems, including asthma. Um, if you, even if you don't think that you have um, reflux, you could. It's sometimes the only symptoms of it are something that don't seem direct, like you don't might not have heartburn, but you might have sinus problems with an asthma exacerbation. Um, so you always should rule it out if you have any suspicion at all that your upper digestive function isn't good. You can always try to improve it and see if that improves your wheezing. Now, there's also a strong contribution of stress, and that is mitigated a lot by your adrenal. It's no mystery that the things that we're using to inhale are actually adrenal compounds. So the glucocorticoids you're inhaling in an inhaler are literally adrenal compounds. Now, they're the synthetic version of them, but the adrenal helps to control inflammation. And when you're very, very stressed, just first of all, the nervous system component of it can worsen things, but so can the inability to appropriately hormonally respond to stress. So, improving adrenal support, if you know that that's your circumstance, actually often improves asthma um, incidence and severity. So, that's like using adrenal adaptogens, using glandulars, things that actually keep your inner physiological stress more supported. Now, as I mentioned before, sleep apnea kind of has a cross relationship to asthma. So it's the actual asthma or the relationship between them is unclear because they definitely are independent of each other as well. But if you have sleep apnea, you can also make asthma worse. Environmental contaminants in your home, like I've already mentioned, the VOCs and the other things that you can do. One of the things that's quite useful if you can stand the cold is using air conditioning or filtration systems on your furnace system. Um, Air conditioning will take out a lot of particulate, especially ones that are externally vented well. And so, like, even in the smoke seasons in Calgary, if you run air conditioning, chances are quite good that you're going to decrease the overall particulate in your home. Because of the cold and the dry in Alberta, we have a much higher particulate load inside our houses than average in a more humid environment. Humidity sometimes obviously makes mold worse, but it also does decrease the amount of particulate in the air because it makes the particulate heavy enough to hit the ground. Depends a little bit on how much humidity, but and last but not least, I do not want to forget or neglect to mention dehydration. Dehydration is a very important regulatory mechanism for many things. One is the termination of histamine responses. So if you have hay fever and you are dehydrated, part of your problem is probably that. The second is it plays a huge role in keeping like appropriate circulation going in and out of a zone. We already know that just giving people an IV in asthma makes things better. And it's probably, especially like in smaller children, people don't have good water habits. You can just make a mess of your asthma. And I don't hear enough people talking about that. And often most of you have had the experience of me being the water Nazi, and I am. I fully admit that for many, many reasons. And this is one of them. It's like one of those no-brainer improvements that you can make. And it certainly improves, like I said, your ability to literally terminate allergic reactions and improve mucus. And we're going to talk about mucus in a second here. So, from a treatment perspective, as I was saying, we want to take a look at, can we handle or decrease the amount of inflammation in this person? So, dietary modifications that are specific, immune regulators that actually keep the immune system a little bit calmer. So, people think about immune dysregulation as always being, my immune system is weak. But in an asthmatic person, it's the immune overactivation that's often a problem. And there's a kind of balance between types of immune reactions. You have types of immune reactions that are meant to be a bit more inflammatory, and you also have types of immune reactions that are supposed to be excretory. The problem is that if you only do one without the other, so there's an imbalance, you might have heard these expressions before, between Th1 responses and Th2 responses. What it actually does is creates an imbalance in inflammation, because you're constantly putting more like fuel on the inflammatory fire by white blood cell activation. And there are plants that can push it back and forth between Th1 and Th2. And some people also will have Th1 responses in their immunology and make it just as bad, because it's a different way of creating an inflammation in the tissue. So normally what I do is I take a look, if I can, if somebody's really serious, try and actually test their interleukins. So those are actually things that you can test in blood that are the indicators of what sort of immunotone you've got going. Or you can just take a ballpark with ART. That often we do in the office, because that's faster to see if we can give you a protocol that calms down the immune system reactions that are imbalanced between those two ends. We can also use allergy regulators. So we can use things that just decrease allergic reactions in general. And some of them are just basic food products that can really decrease your level of allergy. So a great one is EMIQ. That's a concentrated quercetin. We can use things like the lymphatic drainage for allergies. In my practice, I use something called ProAller, but there's many different versions of that. We can use things like nettle. Nettle is very good to help people with allergic tendencies. We can use cromolyn sodium. That's an old treatment for asthma, but it's also an old treatment for hives and those kinds of reactions, and you can still get a hold of that. That's often very stabilizing. So you're looking for something that's going to decrease allergy, but without being too anti. Like I said, easy food molecules don't create big side effects typically. You might also know that in the last couple of years, I have had a protocol for COVID where we've used quercetin pretty extensively, the concentrated quercetin, because it has such a positive impact on respiratory tissues under that kind of inflammation. We can also use respiratory tonic herbs. There's some very good ones like lobelia, although I would use that under supervision because it's quite strong. But you can use it on your feet, like on the soles of your feet, and it actually is absorbed into the bloodstream there and goes first to your lungs. It's very spasmolytic. It actually calms down the bronchial spasms and improves, and it's quite safe to use that with other inhalers and other treatments. You can also use a European plant called butterbur that helps a lot for asthmatic allergy tendencies. Garlic actually helps a lot, and if you eat garlic cloves, for a lot of people, that will decrease the inflammation right in the bronchus. Also another kind of like odorous thing, and if you strap it onto your feet, you can actually smell it on your breath. So same thing as lobelia tincture. Plantain is also another very nice soothing respiratory herb. There are just so many different herbs that you can actually use to improve lung function and clearance. That's just a handful of them, obviously. So, as I've spoken about before, change your diet. There is no one anti-inflammatory diet. And as I was saying before, what are your immune-mediated sensitivities? What's your metabolic type? Um, how balanced is your typical diet compared to the basic ideal diet? And again, this is like something that I've often spoken about in these lectures. You should be eating a half a plate of non-starchy vegetation of all colors, a quarter of a plate of your fats and proteins, a percentage point of ferments, a percentage point of salts or seaweeds, less than 12% fruits and less than 12% starches and grains. So that diet, if you can do nothing else, just adjusting those amounts can make a huge difference in somebody who tends to be more inflamed, because we tend to flip flop those into meat and sugar, and neither of those bodes well in an inflammation a sense. If you know you also have a damaged gut wall and you have rashes or arthritic pains, that's really important, and it could imply that other aspects of gut function need to be attended to. So if that's true for you, find somebody who can help you. If you're not a patient of mine, find somebody who can help you to reset the gut wall. And like we talked about before, if you have indications of microbiome issues, so microbiome issue is you eat a starch and you bloat up, or you eat yogurt and you blow up like within the hour. What that's telling you is you have too many bacteria too high up in your guts. And those bacteria by themselves secrete inflammatory factors, and lots of other compounds that control you and your eating behaviors and even your mental state. So if that's a problem, investigate that. Now, with narrowed airways, there are definitely some things that we can also do. Now, none of these is cures for asthma, but what we're trying to do is look at that three-pronged asthma problem and just add some interventions in. So, in a narrowed airway, lymph drainage is key. And in my practice, I use bronchial syrup and lymphatic drainage for this, and that can be very successful. It is especially successful in children. You could really whip around a wheezer by doing that. And I have had children where I could literally hear them breathing from across the room, uncontrolled asthma, where all we needed to do was to like get it calmed down substantively was to use lymph drainage. And you can also, of course, get people to do lymph drainage on you as a manual technique. And if you have that as a possibility, and that person is great at respiratory treatments, you totally want to take them up on that. That will help a lot. It decongests and moves lymph. Now, lymph is the fluid that's your secondary venous return. So all the serum that doesn't go back as venous blood filters through your tissues and through all your lymphatics, which is where your immune system hangs out. So if your lymphatics are slow, like even if you're dehydrated, as an example, this gums them up a lot. If those are slow, then you get more reactions to things kind of not being moved very quickly. This is the same problem as clearing, in a way, clearing off the histamine reactions. Histamine clearance is a flush reaction. You're literally using fluids to move it off a surface. And lymph drainage is like that too, but it's just underneath the surface. So it can make a big decrease in triggering. Now, breathing exercises is something else. I'm going to talk about that in a moment in a little bit more detail. And you can also use sleep apnea devices to improve narrowed airways, because, like I said, there is this match between sleep apnea and asthma. So breathing exercises do not, again, solve asthma. However, they can make a big difference in a couple of aspects around asthma. Many asthma sufferers are mouth breathers, like because of allergies or stress or attacks. And obviously, cold, dry area is usually an asthma trigger. So if you breathe through your nose, the temperature and humidity of air is normalized by the time it hits the lungs. So cold, dry air is traumatic to the lungs. The nose recovers about 33% of your exhaled heat as well. So you're regulating your body temperature that way. And nostril size regulates volume. So if you breathe through your nose, you actually get 10 to 20% more oxygen uptake because the resistance of the turbinates inside your nose, so these are little structures that whip around the air, reduce the air velocity, and it actually makes a huge difference for snoring or sleep apnea. It's less air actually means better oxygen intake. So you're getting like, if you get partial or total collapse of the trachea and mouth breathing, um, this actually impedes air in a different way. So if your pharynx is toned, so this is like your throat, it will keep the airway open. And a healthy person breathes almost exclusively through the nose during sleep. So if you are not doing that and you are snoring, you can get decreased oxygenation, you can get TMJ aggravations, you can get dental problems, facial and cranial changes, bad breath, cavities, you'll see holes in your molars if you're a mouth breather often. So you can reset some of these issues with breathing exercises. So historically, I've used Buteyko breathing, which is a specific type of retraining breathing. And when you learn how to do that, what you actually do is you decrease the swelling inside your respiratory passages. Again, doesn't solve asthma, but makes it a lot easier to keep air warmed, to keep the breathing appropriate, to decrease swelling overall, especially in the head. And it will increase the condition of airways over time. So it decreases the discomfort for sure. You can also use pursed lip breathing. So that's another one I use a lot, especially if people are hyperventilators under stress. And there's the breathing exercise sheet is actually up on the Whole Life Medicine site under essential handouts. So if you have this feeling like maybe you might be a little bit of a mouth breather or a panter or you're a runner, you really have to take this into consideration and improve your capacity to breathe. Now, again, I'm going to plug hydration in terms of mucus because in asthmatics, what can often happen is people get what are called mucus plugs. That means that the mucus has been sitting there for too long and it gets kind of sticky and it doesn't move very well. And one of the best things to improve the health of a mucous membrane is to improve how much fluid is going through the system. So you can really change mucus plug activity by having somebody well hydrated. You can also use mucolytics. So the best one that I like to use for this is NAC. That stands for N-acetylcysteine. That's basically, again, another kind of food molecule. It's the precursor to glutathione, which is the major antioxidant to the lung, so major repair agent for the lung. But what NAC is really good at, it's good at thinning out secretions. So if people have these pluggy asthma things, or they have COPD, or they have sinusitis that's not moving, or they have pneumonia, this is one of the best molecules you can use for decreasing your mucus consistency, thinning it out and letting your lungs be able to clear it. You don't want to take a mucolytic like that much past 6 p.m. because in essence, what it does is it makes you drown in your own juices. So don't do that. But if you take it early in the day, as you walk around, you actually will find you're going to clear more things out. And probably in about a month, somebody with a lot of mucus can clear a substantial amount of it. Now, you might need to do that regularly, depending on how severe your asthma is, but it's very useful. Now, there's also some evidence for increasing magnesium intake in asthma. Mostly magnesium sulfate is given IV in an asthma attack if nothing else is working in the hospital. Why they don't use that first is kind of beyond me because it's just magnesium. But oral magnesium doesn't seem to have the same direct effect. Now, part of that could just be because you just can't quite get enough magnesium into the bronchial tissue. But it certainly also wouldn't hurt you to not be magnesium deficient. So it definitely seems to decrease like asthma, like clinical improvements. People feel like it's more relaxed, but long term, it's going to take about 8 to 16 weeks with oral magnesium um, to see a difference in asthma indicators. So it's really tells you that sometimes people are just that low. And of course, if you're always in bronchospasm and you're using a lot of magnesium when that's happening, that doesn't help. And being dehydrated doesn't help. Not having enough electrolytes, including magnesium, doesn't help. So it can't really hurt to use it. And like I said, it is does work quite well IV. Now, this seems like a well duh sort of statement, but you want to reduce your triggers if you can figure out what they are. And this is one of the challenging parts of asthma is that people don't do a great job of figuring out the minutia of the triggers. But it's really important to spend some time adjusting and recording triggers or triggered situations and see if you can see trends in it. And see if you can even aggravate it. If you have this sense like this seems to, or when I'm in this environment, it seems to make it worse, or if I eat, at this person's house, it makes it worse. All of those and observations on your own are very, very important. And sometimes you're just going to clue into something. I think you also, and I've I've written down obviously identify and record your triggers. That's super important. You just really want to take note of it. But another thing that's environmental that sometimes should be able to pick up is that sometimes people find mold this way. So mold often really triggers somebody who's already triggered into asthma. And so if you have this problem and you haven't found the mold behind the shower, you'd be surprised how many people get triggered by leaky stuff. So if you have mold, that can make a huge aggravational difference as well. And the only thing to do for mold really is to mitigate it and then use filters for a long time to make sure there's nothing else. Like you pretty much have to hire somebody for mold mitigation, even if it's not black mold. It doesn't have to be black mold. It can just be any kind of mold. And I think, pay attention if things are getting worse. I mean, you'll know your asthma is under control if you're not having symptoms more than 2 days a week, and those symptoms don't wake you from sleep more than once or twice a month. You should be able to do all your normal activities. You shouldn't be taking quick relief medication more than 2 days a week. You shouldn't have more than one asthma attack per year that requires you to take corticosteroids by mouth. And your peak flow shouldn't drop below 80% of your personal best number. And you should probably be tracking it a little bit because sometimes you might actually find a trigger that way. So I am totally sorry I couldn't give you the cure for asthma today, but I hope I've given you a couple of ideas to investigate, especially if you've had trouble with your asthma in the past or you're not 100% sure what makes it worse, or even if you are sure what makes it worse, what are the background factors that you can mitigate to make things a bit better? Now, this is the beginning of the Alleviate webinar series. So we've got a whole bunch of new ones planned for the next year. Now you'll see that there's actually slightly less than usual because normally I would do one almost every month. But because we've had some live events already this year and we're going to have 4 live events a month, I decided doing a live event and a webinar in the same month is just unreasonable for my time. So, because it takes multiple hours to bring some of these webinars to you. So, these are the ones that I have planned for this next series from the end of this month, which is the beginning of the series to next May. And we'll also be doing the next live summer Align event. So the first one was listening to the heart, and this one is going to be listening to the body, so intelligent somatics, basically. Sorry, that got a bit cut off on this slide. And the other webinars that I'm going to have this year is I'm going to have some Helping Dr. Mom webinars, and some of you may not be anymore in the little ones range, but if you know people who are, or you have having kids or grandchildren, these are great webinars for those women who are just in this beginning of motherhood stage. Except, of course, for raising kids in a toxic world, which we can talk about the environmental impacts on children of all ages. So thanks so much for showing up. It's always so wonderful to have people who are curious, and keep showing up to all of these webinar events. And hopefully you're going to be able to share this information with some people who maybe need the information about asthma and implement some of the things we're discussing. And of course, please reach out if you have questions. I'm totally here to help. And if there's any questions on the chat box, I don't think I have any questions on the chat box. Anybody has any burning questions that they would like to ask? Now's your chance. No, you're good. You have some action plans now. Going to take some time to figure out all of these things that you can do. Well, I'm certainly glad to have had you. So thanks for showing up. Sorry about the delay. I know it was a little bit off to have people off by a week, but I apologize. That was an exam that I got a little overwhelmed with. All right, so take care, guys. We will see you at the end of this month for Fitness Myths, and then hopefully we'll see you in July for the next live event. All right, take care. Have a great night.
Thanks for watching. I love to connect to my patient community to inform and inspire, and I hope you'll join us again in the near future. Don't forget to check out whole-life-medicine.com for more webinars and events.